Good afternoon, my dear colleagues. It's my pleasure to welcome all of you to the section on the pathology and COVID-19. I'm very glad online here with my co-chair, Dr. Vũ Thị Phương Thảo, Chief of General Planning Department of Ho Chi Minh Pathology Hospital, and I'm Dr. Vũ Tuấn Anh from Quy Hoà National Laboratory and Pathology Hospital. This is an interesting topic on this time for dermatology to turn to the new normal life and continue all activities in the next periods of post-COVID. In this section, we have a 4 fascinating presentations by Dr. from Ho Chi Minh Pathology Hospital. The first is the general safety principle in cosmetic procedure, presented by Dr. Phạm Ngọc Thạch, is a doctor at Cosmetic Dermatology Department. Second topic is reported by Dr. Trịnh Ngô Bình. We talk about SARS-CoV-2. Can it be sexually transmitted? And the next speaker is Dr. Phương Thảo with her lecture, How COVID-19 is Changing Sun Protection Habit. And the last presentation is Anticoagulants in the Pathology, presented by Dr. Trần Bá Tòng, Department of Surgery. 4 speakers are already now, and I hope all of you will be pleased with their presentation. And first, I would like to introduce the first speaker, Dr. Phạm Ngọc Thạch, to talk about general safety principle in cosmetic procedure. Dr. Thạch, please.
So, hello everyone. It is my pleasure to see all of you again after such a huge pandemic. So recently, our dermatology field has just been through a difficult time. We had to stop almost all of our activities and to go fighting for the pandemic. And we all know that the COVID-19 is going to be long in the future. Thus, the question in my mind is that how to have our clinic open in a safe manner. So that is my aim for this speech. The general safety and cosmetic procedures due to the primary involvement of the face and neck, specifically the perioral and the nasal regions. The nature of our work carries a very high risk of contagion for both the patients and practitioners. But we do have other reasons why we have to put safety into our priority during this era. The first reason is that we usually meet the patients with coughing or sneezing, but also the accompanying persons in the waiting areas. The second reason, I think, is that usually you have small procedure rooms with limited natural ventilations. And in these rooms, we are using central air conditioning. Both of these 2 factors will carry a very high risk of transmission of the virus. Another reason is that in this clinic, we usually cannot keep in adequate distance between the patient and the treating doctor. And some of our procedures can generate aerosols, for example, laser CO2 or ablative fractional laser. And with this procedure, we should put into attention because of high risk of transmission of COVID-19. And the final reason is that long-term exposure with the patient. For example, some kind of therapy of Hamas, we usually spend up to 2 hours per section for each patient. So we should keep in mind that with these reasons, right, safety should be the priority during this era. So my content will be managed to solve 2 main problems. The first is to keep the patients and their relatives safe, as well as the healthcare providers. So we will move on to the patient and the relatives first. I divided into 3 main sections of keeping the patient safe. We can keep the patient safe right from their homes during the visit and after they have just finishing our cosmetic treatment. So before the visit, the patient evaluations and categorization should have been accomplished. We can evaluate the patients by phone call or email or any electronic communications. Our goal is to detect the patients with old age or underlying disease such as chronic lung, kidney, liver, and heart disease. With this patient, we should postpone the treatment until the COVID-19 is stable. And the second information is that the vaccine administration status. We will assess the patient with 2 doses of vaccine or at least 1 dose and 14 days after the first dose, just to make sure that they are safe even they get the COVID-19 during the treatment. And another primary information that I want to mention is we have to make sure that the patient did not in quarantine or has not had any coronavirus symptoms in the last 15 days. And we will make the patient to sign a consent form to create the awareness of them because of the risk of transmission involved with a visit to the clinic, and stress upon the willingness to go ahead with the procedures under the current circumstances. This is crucial as many procedures may require most of the patients to be removed. And this is a kind of consent form that has been obtained from the dental or from the salon and from some cosmetic in America. So we should have take the consent from the patients. And after we get the information, we will categorize the patients. We have symptoms. We have TOCC, it means the travel history, occupation, COVID-19 exposure, or COVID-19 positive cluster. It means that they have just been living or exposed to a cluster of COVID-19 patients, do not have any symptoms, or a TOCC negative. It means that no travel history, no high-risk occupations, no exposure to COVID-19 positive test, or exposure to COVID-19 positive cluster, then the patient can take the consent and provide the treatment using an appropriate PPE, which I will mention later. And otherwise, the patient should postpone the treatment. So before the visit, we can do one thing is to schedule the appointments. I think this is a critical step because when we schedule the patient reasonably, it will help us to minimize the outpatient appointments with minimal stops. And from then, we can keep the social distance in quantity as well as time gap between the patients will depend largely on the size of the waiting area, the chairs we have, the number of treatment available, or the doctors. And during the visit, this is what we can do to minimize the risk of transmission. First of all, to make sure that the patient is going alone without any accompanying persons or family members or even pets, dogs, right? Dogs. Absolutely. And we will have our staff to remind the patients that they have to go on time, absolutely respect for the schedule to maintain the social distance. And important thing is that all financial transaction is carried out electronically. And another thing is in the office, we should determine the rules for the patient in one way only. This will have to reduce the transmission. It will have to reduce the contact of the patients. And after the visit, this is the two main ideas that we should put into consideration. The first is to remind the patients to limit their face-to-face interaction with non-family members to make methods like WhatsApp, Facebook, Zalo, to communicate with the patient and to reduce the post-treatment visits. So we are going to move on to the section safety for the healthcare providers. So in my own opinion, to keep our healthcare providers safe from the coronavirus, there are three main elements. The first is about the environment that they are working in, or the second element is about PPE, which one should be get, and the third is the procedures Do we have to notice anything during the COVID-19 when we are doing these procedures? So we come on to the first element, is about the environment. And of course, cleaning hands will be vital during the COVID-19 pandemic with alcohol-based hand gel. And we are referring the alcohol-based cleanser to antiseptics such as chlorhexidine and iodine. Because the SARS-CoV-2 can survive in the air for up to 3 hours, so we have to open the window at the beginning of the day to remove and disperse the droplets in order to reduce the amount of virus in the air. The second thing to do at the beginning of the day is to disinfect all of the surface with 1% sodium hypochlorite, cleaning the glazer handpiece with ethanol, and change all of the disposable patches for a patient. And at the end of the day, we also fog, at least in the procedure rooms, with the hypochlorite sodium or hydrogen peroxide and silver nitrate. And what about the PPE? Recently, we have 4 types of PPE that we can use. I think that we get used to this type of PPE quite well during the pandemic. It's a full coverall, N95, gloves, caps, face shield, and goggles. And the second type is that N95, gloves, caps, face shield, and goggles. And the third is the power air purifying respirator, gloves, and gloves. This kind of respirator is quite expensive, much more expensive than the N95, and is not readily available in Vietnam. And the third is a surgical mask and shield. And of course, this is what we are using at the beginning of the pandemic. So which one should we choose during this era, during the post-COVID-19 time like this? According to the consensus that has just been made by experts, and I think that the reception desk will carry just a low risk, so they can wear the surgical mask only. And the second position is the screening staff, and of course they will carry a moderate risk, and they can use N95 with a gown. And the high risk, of course, the therapist, they will carry moderate to high risk, depends on the patient, depends on the procedures, and the procedures that create aerosol will have to wear the full PPE, and otherwise they can just wear N95 and the gown. And finally, last but not least, is the housekeeping. They carry the moderate risk, so they should also wear surgical masks as well as elbow level rubber gloves and a plastic apron. But during the pandemic, there was time that the N95 was not enough for us to use. There was a shortage of N95, and as we know that this is the global phenomenon, as well. In the developed countries, they still reuse the N95. Actually, there are 2 ways for us to reuse the N95, and I believe that this is will be helpful for us to use in the next coming days. So, in order to reuse the N95, we have 5 bags. We should prepare 5 paper brown bags, breathable bags. And after we have already used the first bag, we will place into the paper bag and allow to dry for 4 days. And the same for the second, the third, the fourth, and the 5th. And on day 6, the first mask should be reused on the 7th and the second mask, and sequentially to the last. And each mask like this can be used for up to 5 times before they get discarded. And another way, instead of using the paper bag, we can now use the UVC. And this is the UVC system 254 nanometers at the appropriate dosing, they can disinfect the coronavirus as well as reduce significantly the Clostridium difficile or MRSA. And final, last but not least, this is about the procedures. This will be further discussed by other speakers in a more detailed way. So, but I'm going to tell all about some general principles of the cosmetic procedure during the COVID-19. So we can categorize the procedure into three main groups. The first is the low risk, the medium risk, and the high risk. With the low risk procedure, which is defined as it doesn't create aerosol with short durations and with non-facial or facial area, but with mask on. And the physician in this case should wear N95, surgical cap, face shield, disposable gown, and gloves. So to come into the conclusions and take home some messages. The first message I would want to send is that COVID-19 is going to be long, so please prepare for that. And everyone can get infected, so please stay strong, stay healthy, and be prepared. The second is we can achieve the patient safety by using the patient classification before they enter the clinic and a reasonable scheduling the appointment so to make sure that the social distance is warranted. And the consent form, we should do the consent form to raise the patient awareness that they have to protect themselves, they have to receive full responsibility when they get infected COVID-19 during this era, when they come to our department to do the treatment. And finally, last but not least, we can also achieve the healthcare worker safety via cleaning the environment frequently, using the correct PPE, and notice to the procedure safety. So that is all for my presentation. Thank you for your attention.
Good evening, ladies and gentlemen. Today, I would like to give you a presentation about the topic SARS-CoV-2 can it be sexually transmitted. My presentation is divided into 6 sections: the introduction, the mechanism of the SARS-CoV-2 transmission, the penis-vaginal route, the oral-genital route, the oral-anal or penis-anal route, and the last one is the sexual practice during the COVID-19 pandemic. As you may know, SARS-CoV-2 is a short term of severe acute respiratory syndrome coronavirus. The virus is spreading worldwide since the first case reported in Wuhan, China in December 2019. The virus targets many organs such as pulmonary, cardiovascular, renal, and gastrointestinal tract. As a result, many complications can be seen, such as acute respiratory distress syndrome, cardiovascular system damage, kidney injury, digestive system disturbance. There are 2 main ways of transmission, direct and indirect. The transmission of the SARS-CoV-2 can occur through infected situation when an infected person coughs, sneezes, talks, or sings. Moreover, the infected individuals can expel the droplets on the surface or objects from hours to days. However, do you know COVID-19 is sexually transmitted disease? Let's move to another part, the mechanism. There are two main receptors play an important role in the mechanism of SARS-CoV-2 infection. The capability of SARS-CoV-2 entry via ACE2 receptor, which binds to protein of the virus and activate surface TMPRSS2 to facilitate the virus receptor fusion. Looking at from the bar chart, you can see that the ACE2 and TMPRSS2 can be found on prostate gland, urethra, testes, and ovary. Let's move to another part about the ways of transmission. The first rule I want to mention is the penis vaginal rule. Figure A tells us about the spermatogenesis process. The figure B describes the ACE2 and TMPRSS2 expression among various stages of reproductive male genitalia. This is a systematic review on the investigation of SARS-CoV-2 in semen. Based on the current literature, the authors confirmed the presence of SARS-CoV-2 in semen in 1 out of the 8 reported studies and totaling 4.3% of the population strain. The ACE2 expression is higher in the lung, intestine, and kidney, but it was also high in urothelial cells, which may be a link with lower urinary tract symptoms. This study was conducted on 10 patients to know whether the SARS-CoV-2 in the urethral swab or not. Interestingly, the result tells us all 10 patients had a negative urethral swab for SARS-CoV-2, although the renal oropharyngeal swab was positive for SARS-CoV-2. Let's move on the female genital tract. According to the RNA sequencing data, 7 ovarian cell types show that the degree of ACE2 and TMPRSS2 co-expression enriched with the oocyte maturity. The ACE2 is more predominantly expressed in the oocyte than TMPRSS2. This study to evaluate the SARS-CoV-2 in the vaginal secretions of women with COVID-19. The study concluded that detection of SARS-CoV-2 in vaginal secretions of patients diagnosed with COVID-19 is rare. Another study from China was carried on 10 women with confirmed severe COVID-19 pneumonia. The study also confirmed that no SARS-CoV-2 virus existing in vaginal fluids of severe COVID-19 patients. Another study from Turkey was conducted on women who was between the ages of 18 to 50 years. The study also tells us SARS-CoV virus were not detected in vaginal fluids of the patients who tested positive for COVID-19. Now we talk about a systematic review is sexual transmitted disease caused by the coronavirus. Based on the current worst public information, COVID-19 is not an STD. Let's move to another rule of transmission, oral genital rule. Viral particles may be transmitted through oral sex and use of saliva as lubricant. How about the oral anal or penis anal rule? The ACE2 messenger RNA is highly expressed in the gastrointestinal system, and the immunoproliferation data show that the ACE2 protein is abundantly present in the granular cells of rectal epithelium. ACE2 also can be found on the mucosa of oral cavity. Another study on infants with a COVID-19 who continue to test positive in the anal swabs, even after 14 days of testing negative by nasopharyngeal swab test. Therefore, maybe two ways of transmission, directly and indirectly. Directly, that means through oral anal contact. Indirectly means with exposure with the rectal mucosa to the saliva for lubrication during anal sex. We talk about the last one of my presentation, sexual practice. If a partner is living in the same household, after passing quarantine time, they recommend that having regular sex. If a partner during the quarantine time, sexual activity with condom and with coital penetrative positions, avoid kissing, oral and anal sex. If a partner with any suspicious clinic at any time, avoid coital sexual activity for 28 days. Or a partner with positive COVID-19, avoid coital sexual activity for 28 days. How about the pregnant? Sexual activity with posterior penetrative position is recommended. Avoid kissing, oral, and anal sex. Use condoms. If the partner in contact with the patient who was diagnosed with COVID-19, they recommend that avoid coital sexual activity. How about the partner is not living in the same household? Avoid sporadic couple, use of condom, dental dam, and similar protection methods during intercourse. In conclusion, there was no study to evaluate the risk of sexual intercourse in the COVID-19 pandemic period. The patients remained positive for COVID-19 increase after pharyngeal swab turned negative. Vaginal transudate is free of SARS-CoV-2. It is unknown whether there is a relationship between sexual practice and the risk of spreading SARS-CoV-2. Thank you for your listening.
Good afternoon, ladies and gentlemen. It's such a pleasure for me to give my presentation today. And the topic of my presentation today is about how COVID-19 is changing sun protection habit. And as we know, COVID-19 pandemic has become a worldwide problem. and it has changed attitude and behaviors concerning cosmetic care and procedure among patients presenting to the dermatology outpatients clinics. And as this table shows that, we can see that before the pandemic and during the pandemic, the usings of the cosmetic products is not having the significant differences between the usings of cleanser, anti-aging product, moisturizer, anti-spot product, and also the sunscreen. However, specifically using of the sunscreen before and during the pandemic, we can see that the using of sunscreen on the face, around the eyes, and also the body before the pandemic and during the pandemic, people have the tendency to reduce the using of sunscreen. And the reason for this reducing of using sunscreen is maybe because due to the three main reasons, in my opinion. The first one is that people who think that they stay at home and because of the social distancing, they stay at home so that they can avoid from the direct contact to the UV radiations, so that they do not need to use the sunscreen, or they do not need to wear the sunscreen anymore because they do not have the direct contact. And the second reason is that because we have to wear mask for a long time, and if we wear mask for a long time, it covers most of the part of the face, so that they do not need to use the sunscreen underneath the mask. And last but not least, the chemical sunscreen sensitivity and comedogenicity increased under occlusions. So that because of the occlusions, it can cause maskne if they have to wear mask for a long time. And because of the afraid of having maskne, so that the patient afraid to use the sunscreen because it can make the occlusions is more severe. And with that three reasons that make the people have the tendency to reduce the using of sunscreen. And thus the fact that reducing using sunscreen in the COVID-19 pandemic can cause the skin problems, we will figure out in the next slide. And with the first reasons, if people thinking that they stay at home to fight coronavirus, and because of stay inside, they do not have the direct contact to the UV radiations, so that they can protect from the sunlight. And how about the realities? The reality is that the lockdown had curbed the processes of melanogenesis, hyperkeratosis, and epidermal hyperplasia in response to the gradual adapt of the skin to sunlight, and so that it's making the skin more sensitive to more aggressive and energetic solar irradiations. And in addition, the photoimmune response may be affected by the fact of by the lack of exposure to sunlight, thus favoring an increase in the incidence of photosensitivity disorder. People who keen to be outdoors after the long lockdown period, there is clearly an increased risk of sunburn, and the skin has had no time to adapt, and this could have long-term repercussions in the form of an increased incidence of skin cancer. And so that with the first reason, if people think that they stay at home, they stay away from the sunlight, but that is not true. If they stay at home, it makes the skin more sensitive to UV radiation, so that if it contact to the UV radiations, they can easily get the sunburn or increase the risk of skin cancer. And how about the second reason? With the second reason, if they think that they wear a mask, they do not need to use the sunscreen underneath the mask. And how about the realities? And the reality is that the surgical masks and respirators, for example, the N95, are tested for bacterial filtration efficiency, particle filtrations, breathing resistance, and splash resistance. To our knowledge, the UPF of this product is largely unknown, likely because medical masks were not designed with the intention of being used outdoors or outside of healthcare settings. An analysis of medical masks in this context is difficult because the UV protection of this material depends on the type and quantity of fiber additives, such as antioxidant or UV stabilizers. And the first medical mask is the surgical mask, and the surgical masks are most commonly made of 3 to 4 layers of non-woven polypropylene, which is a raw fiber is highly susceptible to oxidative degradation for both UV radiations and visible light. In recent study, the polypropylene transmitted 40 to 70% of UV rays and only have a UBF between the 6 to 11. And how about the respirators, such as N95s? The respirators, such as N95, are made of several non-woven synthetic layers and offer better virus filtrations due to electrostatic charge and are closer to the face. And the ultrafine filtration layer is typically composed of meltable polypropylene that is then placed between multiple other polyester layers. So that can make the respirators such as N95 likely better than surgical masks for sun protections due to their polyester content. However, given the shortage of respirators during the pandemic, they are not recommended to the public for UV protections because the UPF of the N95 is really unknown. And so that both surgical masks and also the respirators such as N95 is not recommended for UV protections. And surprisingly, homemade cloth masks earn UVB protection score of between the 400 and 500. Such values are not likely to be reached with topical products with limited, for which the 2006 recommendations limited display value to 50 over for an experimental determined value greater than 60 have the UPF and UBF UVA. And we can see that the most study based on the literature, the best mask choice for sun-aware consumer is a black, dense woven 3-layer mask composed of polyester or a combination of polyester and natural fibers. And the ultimate method of ensuring excellent UV protection is to select a mask with a UPF 50 label and a seal of a reputable organization. And the fact is that if people thinking that they wear mask is enough and they do not need to use the sunscreen underneath the mask because the mask can cover most part of the face, it is not true because we can have some part the mask only, not cover all of the face. We still have some part of the face not covered by the mask like the forehead and also the ear. And the secondly reasons is that if they cover the mask, it can make the patient incautious with the sun UV radiation because they think that they have the mask so that they do not seek for the shade or they do not need to use the additional physical protection from the sunlight. And it can cause the harmful effect on the skin. And last but not least, if we wear masks for a long time, it can cause masking and it will harmful for the skin. And so that we analyze the second reasons. If we think that the patient wear mask for a long time and it will protect the skin from the sunlight, it is not true because both the surgical mask and the respirators such as N95 have not recommended for UV protections. And not only they do not have the UV protections, but they can make the patient incautious because it can make the patient incautious with the UV with the sunlight, and they do not seek for the shade or they do not use additional physical protection from the sunlight. And last but not least, we stay at home and we have to work from home. And by some estimate, we spend 50% of our life staring at the screen. And especially during the COVID-19 pandemic, we have to work from home. And when many of us are spending more time indoors and in front of screens like the laptop and also the smartphone than normal, we are substantially increasing our exposure. And we are exposure more to the blue light like the laptop and the sunscreen and like the laptop and also the smartphone. So it's particularly important to understand the effects of blue light. So what is the blue light and how about the characteristic of blue light? And the spectral characteristic of visible light induced pigmentation and visible light protection factor have been described in 2019 by Indemnith Coley. And also we can see that the light emitted from smartphone screen and taking selfies can cause premature aging and wrinkle. And also, the visible light can cause some harmful effect in photodermatology. And the source of light beyond the UV, we can see that visible light, especially the violet blue high energy visible light, have been shown to cause indirect DNA damage via generation of free radicals and oxidative stress. In fact, 50% of the generated growth in the skin during sun exposure have been associated with the visible light portion of the solar radiation, so that the visible light can cause much harmful for the skin, much more than UVA and UVB. And we have many sources of light beyond the UV. With the outdoors, we have the solar radiation. And with the indoors, we have the energy efficient artificial light sources like the LED and the compact fluorescent light have more than 30% of high energy visible light emissions. And with the electronic device, if we think that we use more electronic device is not harmful for your skin, it is not true, and you are so wrong, because the electronic device like the smartphone, the laptop, and the TV screen, computer monitors can emit more than 30% of the high energy visible light, and it can cause harmful for the skin too. And we can figure out, we analyzes the high energy visible light effects, and we can figure out that why the high energy visible light have the harmful effect on the skin. And high energy visible light effects can make the reactive oxygen species are generated, and it can lead to the DNA damage and thereby causing inflammations and the breakdown of the healthy collagen and elastin, and it can make the face more wrinkles and its uneven texture on the face, as well as the hyperpigmentations. And blue light has been reported contribute to the eye strain as well as cataracts, glaucoma, and other eye disease. And to prevent these conditions, keep at least 12 inches between you and your screen and take frequently break. And we can see that as we now, there are no commonly understood the threshold for when time spent in front of a screen starts to show on your skin. And so that we need to use the sunscreen to protect our skin, not only from the UV radiation, but also from the visible light. And we have many reviews that talk about that problem. And in this review, we can see that the tinted sunscreen are beneficial for patients with visible light induced photodermatose and those with hyperpigmentation disorders such as melasma and post-inflammatory hyperpigmentations. And also have a new proposal for evaluations the effect of sunscreen protection against visible light, and it also showed that pigmented product provide more effective photo protection within that band. And so that if we use the tinted screen, can help us against the visible light. And for the conclusions, our review highlighting the UV protection property of mask raised the questions. Mask cannot have adequate sun protection alone, and this sunscreen use under the mask also required. And since the UV filtration level conferred by individual masks is largely unknown, so that it may be wise to wear sunscreen underneath the face mask, and we need to use the broad spectrum sunscreen under the face mask is recommended. And we not only protect our skin from UV radiation, but also the visible light, and so that it is recommended to use the tinted sunscreen. And we need to know that the protect not only for the face but also for the ear and the hand and the body, and it we protect the skin well in front of the sunlight, we can reduce the severity of skin conditions exacerbated by sunlight, for example, melasma and skin cancer during the pandemic. And this is the end of my presentation. Thank you so much for your pay attention.
Afternoon, everyone. 4 years ago, anticoagulants are unfamiliar drug class with dermatologists, but the COVID pandemic has changed everything. In field hospitals, anticoagulants as well as systemic corticosteroids are widely used by dermatologists and physicians in other specialties to treat severe COVID patients. So are there any other applications of anticoagulants in dermatology? And are there any other issues that the dermatologist should be aware of when treating patients who are on anticoagulants? My presentations have 4 parts. First one, I will talk about the group of anticoagulants. This is the coagulation cascade that we all knew back when we were a medical student. But just not skip it. All right, there are 4 groups of anticoagulants. The first one is heparins, which include unfractionated heparin, which we also call heparin, and also low molecular weight heparin, enoxaparin. The second one is vitamin K antagonist, which include warfarin and azenocumarant. The third one is factor Xa inhibitor, direct factor Xa inhibitors. They have rivaroxaban and apixaban, and the final one is direct thrombin inhibitors. Yeah, they have the biggest range. So the difference between the direct inhibitors and the other 2 groups is in the direct inhibitors, rivaroxaban, apixaban, the biggest range, they directly bind to factor Xa or factor 2 to inhibit them, and they can be taken by mouth, which give them the name DOAC, direct oral anticoagulant. In case of heparin, they have to bind to another protein before they can inhibit factor Xa and factor 2. So anticoagulants are used to treat venous thromboembolisms such as deep venous thrombosis, pulmonary embolisms, and acute coronary syndrome. They can also be used to prevent thrombosis in patients with atrial fibrillations, after myocardial infarctions, patients with prosthetic heart valve, or in bedridden patients who have undergone automated surgery. So what are the adverse events of anticoagulants? The first one is skin necrosis, which have been reported to be caused by heparin, vitamin K antagonist, and DOAC. The mechanism is the imbalance between anticoagulant and proagulant, and in case of heparin-induced thrombocytopenia. We need to stop a drug and switch to another anticoagulant, and the patients may need skin debridement or skin grafting. The lesion usually start with more petechia and then progress to ecchymosis and hemorrhagic bullae. And ultimately, it can worsen to complete skin necrosis, which can infiltrate deep into the subcutaneous fat, which lead to infection, sepsis, or even death. The second adverse reactions in non-nephrogenic calciphylaxis, which is calciphylaxis in people with normal kidney functions, and it's only been reported to be called by warfarin. And luckily, warfarin nowadays have been replaced mostly by other newer and safer anticoagulants. The lesion usually start with erythematous or skin color deep-seated nodules in the lower legs, and then progress to retiform purpura. As you can see here, this is retiform purpura, and then central necrosis with dry eschar. And on histology, we can see that there is calcium inside the blood vessel. And of course, we need to stop a drug and use intravenous sodium thiosulfate to treat the patients. The third one is urticaria and hypersensitivity reactions. These are rather common drug reactions, not only with anticoagulants, and it has been reported to be caused by heparin, vitamin K, and DOAC. we need to stop the drug and use systemic corticosteroid for the patients. The final one is a cutaneous leukocytoclastic vasculitis, LCV. And again, heparin vitamin K antagonist in DOAC can cause the reactions. And they usually start with palpable, petechia, and purpuric, non-blanchable purpura. And then with the focal ischemia and superficial infarction, superficial skin infarctions can develop, which can progress to vesicular or hemorrhagic poly, and ultimately to ulceration plaque of papules. And this is the histology of vasculitis. We can see that the blood vessel walls is destroyed by many cells. There is fibrinal necrosis inside the blood vessel, and also extravasated black blood cells around. So let's move to another part. Antithrombic medications in cutaneous surgery. All people, nowadays the average skin patients are all people in their 6th to 7th, 8th decade who are on anticoagulants because of their comorbidities. And with the ever-increasing number of dermatology surgical patients presenting from dermatology surgery, the dermatology surgeon had to face a challenge to managing the drug because the patients, they're also on anticoagulants. In order to balance the risk between the thromboembolic events, which can be life-threatening, and the bleeding complication. So what did he do? In the 1990s, they routinely stopped all the anticoagulant and antiplatelet medications several days prior to the surgery in fear of bleeding complications. And what happened? There are reports of patients experienced post-operative stroke after their warfarin was stopping 3 to 7 days before cutaneous surgery. And Alam et al. Also report severe adverse vascular events, including pulmonary embolism and even death in patients who anticoagulants were discontinued prior to surgery. And several case report and retrospective study have also emphasized the risk of increased thromboembolic complications in patients whose there's medications such as anticoagulant and antiplatelet therapy were discontinued prior to cutaneous surgery. So in 2011, there were a prospective study was conducted to evaluate dermatology surgery complications in patients who was on multiple platelet and anticoagulant medication. And the study was conducted in 15 months involving 1,911 patients. And before surgery, the following data were collected on the questionnaire whether or not the patients were on immunosuppressant or whether or not they are taking oral anticoagulant or antiplatelet medication. And after the surgery, the absence or presence of these complications were collected by the physician: perioperative hemorrhage, post-operative hemorrhage, hematoma formations, infection, and flap of cleft necrosis. And this is the result. Using multivariable analysis of bleeding complications, they found that warfarin and clopidogrel were significantly associated with bleeding complication, and also flap, cleft partial closure also significantly associated with bleeding complications. And although their results demonstrate that the patients on warfarin have a significantly higher risk of bleeding complications, but none of these complications were severe enough to necessitate management outside the office setting. And in their capsule summary, they recognize that the risk of complications for patients undergoing cutaneous surgery is extremely low. And in patients taking both warfarin or clopidogrel, although they have a higher risk of bleeding, however, this medication should be continued to avoid the risk of life-threatening adverse thrombotic events such as stroke or myocardial infarction. And this is a review of traditional and novel oral anticoagulant and antiplatelet therapy for dermatologists and dermatology surgeons, published in 2015. And in the general guideline, they also said that anticoagulant and antiplatelet therapy should be continued before the medication, before the surgery. And of course, because there is increased risk of bleeding complications, appropriate measures should be taken intraoperatively to ensure adequate hemostasis, and appropriate post-operative pressure dressing can be used for 24 to 48 hours to promote continued hemostasis. All right, so let's move to the final part, the skin and hypocoagulable state. So what is hypocoagulable state? Yeah, with hypocoagulable state, the patients are much more, the patient blood is much more to thrombose in the veins and in the arteries, and venous thrombosis can include deep venous thromboembolisms or pulmonary embolisms, and arterial thrombosis include myocardial infarction and stroke. So we all know that COVID-19 can induce a hypercoagulable state. This is the cutaneous manifestation in patients with COVID-19. Yeah, this is lipido racemosa, and this is acrocyanosis. You can see it, their finger, their toes, this is deep purple. This means they are obstructed blood vessels. And in most of the patients, the D-dimer and fibrinogens are elevated, and they are treated with anticoagulants such as low-molecular weight heparin. And this is also another cutaneous manifestations of COVID-19, which is due to the hypercoagulable state, retiform purpura. The purpura in general is not specific for hypercoagulability, but when they are retiform purpura, it's highly specific, and this patient can also be treated with anticoagulants. It's other manifestation, lipidolaticularis, petechia, that can be met, that we can see in vivo with hypercoagulabilities, anatoderma, purpura, and lipidovasculopathy. So hypercoagulable state is not a uniform disease, but a complex conditions which result from a variety of primary and more commonly secondary conditions such as hospitalization, surgery, or patients taking medications such as estrogens, replacement therapy, or oral contraceptive pills, or as discussed earlier, anticoagulants can paradoxically induce hypercoagulability. And of course, COVID-19, an infectious disease recently described. And because the cutaneous manifestations of hypercoagulable state are not specific for certain conditions, when recognized the finding, a dermatologist should perform a skin biopsy and laboratory test to further evaluate for an underlying thrombophilic disease, such as gene mutations, antiphospholipid antibodies. So let's talk about a rather specific manifestations of hypercoagulability. It is called lipidovasculopathy. It is a chronic, painful, recurrent, and progressive skin disease, affect mostly the malleolar regions and also aspects of the feet, with skin ischemia and subsequent painful ulceration, and it is extremely painful. As you can see, it's mostly affecting ankle regions of the feet. And the main differential diagnosis of lipidovasculopathy is cutaneous leukocytoclastic vasculitis, because they are both disease affecting the lower legs. But when we pay much attention, we can see that in vasculitis, there is non-plunging palpable purpura affect not only around the ankle regions, but also the legs. But in lipidovasculopathy, mostly it deep-seated nodules with ulcerate, leaving wide atrophic scar around the ankle regions. So this is the histology between those two diseases. In lipidovasculopathy, we see the thrombosis inside the blood vessel lumen, but around them there is minimal to no inflammatory cell infiltrate. It is contrast to vasculitis, where there are a lot of cells infiltrate and attacking the blood vessel wall, resulting in the destruction of the blood vessel. So because lipidoid vasculopathy is a manifestation of hypercoagulability, what drug we use to treat them? Yeah, of course we use anticoagulant and antiplatelet therapy such as rivaroxaban, enoxaparin, warfarin, or aspirin. We don't use immunosuppressants or anti-inflammatory drugs to treat a hypercoagulable state. And this is the end of my presentation. Thank you.
Now, thank you so much for the four speakers for the excellent presentation. And now we go to the discussions. And now we have one questions here. I introduce my co-chair, Dr. Vũ Tuấn Anh, to give these questions to Dr. Huy, please. Okay.
So the question for Dr. Huy is, the 5-pocket method is reused and 95 is very interesting because there is someone that has this mask on the wall and shrink, but is that because the contamination is very high, especially in crowded department? What do you think about the hot climate in Vietnam can make the mask acne is more bad with this reused mask? Can you share your experience, please?
Yes. Can you listen to me?
Yes.
Yes, thank you. First of all, I want to say thank you for your very good questions. Actually, the 5 pockets method is not mine, but it's published on the paper, and it shows that using these kinds of methods can help us to reuse the N95 mask. And actually, the N95 mask is going to be used for long, and it is inevitable to change. And N95 is quite expensive, so reducing them in this era is quite practical. Actually, the method that you say that you using a wall or string is largely used in Vietnam because we do not have the process to have to clean the N95 without damaging the structure of the mask. But actually, we can use this method, and in this case, when we reuse the mask, we may get some side effects of using the mask, like you say, the mask acne, and sometimes you can get erythema, irritation, for example. Actually, this is the fact that I think that we have to take account. And in my own experience, I see that first of all, we have to change our skincare routine. So before we using the mask N95 again, we can try not to wear the makeup or using, we should use gentle cleanser before wearing the mask. And if in case your skin is oily, we can try to use the moisturizers that can reduce the amount of oil before wearing the mask. And after you take off the mask, so please remember to keep your skin clean is very important. So immediately to cleanse your skin with the cleansers containing salicylic acid or sulfur, because these kinds of ingredients can keep your pore clean. And in case you have pimples, you can try to use the benzoyl peroxide and look for anti-inflammatory ingredients like niacinamide or azelaic acid. It will have to reduce pimples as well as to reduce the inflammatory caused by the mask. So if you try using this method, you can get familiar with this or not, but you can get familiar without any side effects like erythema, irritation, or acne. This is good for you and you can use it. Or if not, you can try to use another mask, not N95. Thank you for your questions.
Thank you, Dr. Huy. And now there are some questions on chat box to Dr. Thảo. Which color of cloth mask is better for preventing UV? And tighter sunscreen need enough 2 mg per centimeter square on skin ensure protection. It is very heavy. And the last is, do I apply normal sunscreen first and cover by time sunscreen after that? Is it enough? Dr. Thảo, please.
Yes, thank you for your questions. And our attendees is pay attention a lot about the sunscreen during the COVID-19 pandemic. And it's my pleasure to give these presentations today. And I will answer 3 questions. The first question is, which color of cloth mask is better for preventing UV? And based on the literature, the best mask choice for sun-aware consumers is a black, dense woven 3-layer mask composed of polyester or combination of polyester and natural fibers. So that if we need the UV protection, UVF of the mask, we need to use the darker, like the brown or the black mask is better than the brighter mask. And with the second questions, tinted sunscreen need enough 2 milligrams per centimeter on skin for ensure protection. It is very heavy, and it is true that if you apply the enough quantity, it can make your face very heavy. And not only the tinted screen, but also every sunscreen, you need to wear enough the quantity to get the enough UV protection for your face. But I have a tips for you if you don't want to put such that heavy quantity of sunscreen, because the SPF dose response curve was linear in the range of 0.5 to 1.5 milligram per centimeter for every octocrylene formula tested. So that if you use a product that have a high SPF, if you apply not enough the quantity and maybe the SPF reduced, and if we use the higher SPF when it is reduced, we can get the enough SPF with that sunscreen too. And the last questions, do I apply normal sunscreen first and cover by tinted sunscreen after that? Is it enough? So we do not need to use 2 kinds of sunscreen like the normal sunscreen, and after that we cover by a tinted sunscreen. We only need to use one sunscreen that have the broad spectrum sunscreen. It can protect your skin from the UV radiation and also the visible light. So that if you need to wear the sunscreen, you should choose a tinted sunscreen that can have the enough SPF value and also have the effect to protect your skin against visible light too.
Thank you, Dr. Thảo. And any question?
And I see here one more questions about the sunscreen. From Dr. Thu Trang. SPF is not related to high energy visible light protection, as I know. Yes, that's correct. If you choose the higher SPF, it does not mean that you have the high energy visible light protection. You need to choose the cream that have broad spectrum sunscreen. It can protect your skin from the high energy visible light, especially the tinted cream have the efficacy against the visible light. It's better than the clear gel or the clear sunscreen.
Okay, speaker and audience have any question?
As I see, we have no more questions from the Q&A and also the chat box too. And regarding the chairman, I will announce that we have been through 4 excellent presentations about the dermatology and COVID-19, and I would like to say a very big thank you for our speaker to give the excellent presentations. And we will end these sections to move on the next session. Thank you so much for your attention.
Thank you.
Thank you, Ron. Goodbye.